I'm going to talk about outpatient competency restoration, and I have with me Michael Wente, who is the program director of one of the outpatient competency restoration programs in Ohio at NetCare Forensic Services. So Ohio has done and has had the capacity to do outpatient competency restoration really for quite some time. It just wasn't an organized effort, and there wasn't funding behind it. So there were a scattering of programs around Ohio, just a few, that were often locally supported, sometimes through funds, through their local ADAM board or other sources. Twin Valley Behavioral Health Care had run an outpatient competency restoration program really starting back 25 years ago, and really served as a nice pilot to see what could be done in the community. After Senate Bill 2 had passed, there then became some GRF funding to upstand and serve the state of Ohio with outpatient competency restoration services. And with that funding, we had to figure out an infrastructure to have the availability of this service out to all the courts in Ohio. So with that funding, 10 programs were organized around the state, and most of them would serve a catchment area of counties. Now, to serve a catchment area and to serve some of the rural communities where there isn't high volume, there had to be a way to get those services out to individuals. So with the really uptick in telehealth and telehealth services, that's really how these programs operate, is that combination of either in-person and or telehealth. The next fiscal year, we really worked on developing these programs, some marketing materials, making sure the courts are aware they exist, and some of the parameters around them. And this last year, really looking at refining those processes, serving more individuals, and improving those programs. So we have some really preliminary data. This is 5 quarters worth of data for the outpatient competency restoration programs around Ohio. As of, I believe the slide was put together about a month or 2 ago, and we were at 350 individuals that had been served in the outpatient programs since the fall of 22. About 50% restoration rate, and you can see the blue and the orange delineate the difference of charges, the orange being those with misdemeanor charges and the blue being those with felony charges. So although the programs are there and really got their funding related to SB 2 and those nonviolent misdemeanor cases, it doesn't restrict it to just misdemeanor cases. And with that, I'm going to turn it over to Michael Wente to go a little deeper with you into one of these programs, what they do, who they serve, how they serve, and give you the details.
Thank you, Lisa. My name is Michael Wente. I'm the manager of Outpatient Competency Restoration at NetCare's Forensic Center. We started our program on July 1st of last summer. I joined, about 1 year exactly to the day from now. So we got about 2 months in advance of launching our program and spent the majority of that time reaching out to the courts, trying to communicate to everybody that after 2.5 decades, Twin Valley was no longer the original provider, and now we're taking over. There were some sluggish responses to that, so we've learned how to reinitiate this information as we go. We're really learning how to launch some new information to some new sources in a short amount of time. Currently, we're serving 96 defendants, or 96 have been served and ordered to OCR. We're serving 17 counties. Our current caseload is 32 defendants. All of this information outside of the counties is now inaccurate. It was provided on Monday, and our total caseload is now like 103, and our active cases is 38. So if that doesn't sum up OCR in the last year, I don't know who it really does. We took over additional counties from another forensic center because there was a manpower shortage, which really showed us how, as a system, we have to adapt and work together so that these services can be provided. Dr. Gordish was instrumental in connecting some dots and helping us directly connect with the courts themselves, and again, another example of problem solving on the fly. Before we started, our first plan was we got to talk to everybody who has a hand in the cookie jar. So we met with all the local ADAM boards who were overseeing counties that we were originally assigned. We're starting to implement those same conversations with some of the counties that we've added. We met with all of the outpatient agencies that we think are going to be primary players in these games. A little harder in Franklin County when we have such a large source of outpatient services. But in some of the smaller surrounding counties, BHP in Licking County is the king of all kings. So it makes it a little easier to connect with the one agency that might be overseeing the services these people are receiving when they're not in the correctional setting. Access to wellness. I owe Dave Foreman a shout out here for helping me become a member of the advisory committee. And Access to Wellness is a specialized group of funds, basically wraparound support services for people using multiple systems within our adult care system. So we've already had a whole lot of referrals. I don't even know the data on those. Lisa, you might have a better idea, because what I've seen is I send the referral and then the action team who actually knows what they're doing takes it and runs. So we do have a lot of people now aware of OCR and the expansion of OCR falling into the criteria of some new money that's available for service. We've met with Department of Developmental Disabilities. What I learned was that the CDC is also providing competency restoration to people who are on their residential facility. So we've used some of their ideas to work with some of our maybe lower intellectual functioning defendants, and now some of their concepts are implemented into our programming. We've met with as many people as you can imagine in the court. I don't have to name all the different titles. Court administrators, probation departments, public defenders, prosecutors, members and administrators of specialized dockets. It is very surprising how many people contact me who I've never heard of, who have very important roles and have helped us learn what different resources for support are out there. One of the biggest things is we at NetCare complete a lot of front-end and initial competency evaluations, and with the change of SB2 and the change of who falls into this new OCR category, well, it opens up a lot of options and a lot of questions for our evaluators. I should shout out John Tilley. I think I saw him around here. Dr. Tilley has been very helpful in tolerating my constant outreach to pick his brain. Dr. Tilley completes all the front-end evaluations for Franklin County Muni Court, so everybody he recommends ends up in my program. So one of the first things we wanted to do was, hey, John, who do you see as appropriate? Who do we see as inappropriate? And how do we prove that we know what we're talking about? So the idea is we're creating a data stream so we can try to identify some of those early indicators of who might likely be restored. For our programming highlights, one of the first things that I personally took offense to was we need to redo the documentation for the OCR program to make it more valuable to our evaluators and to our courts. If somebody's going to be in a program that's court-ordered, why would we not make our documentation mirror something that should also be subpoenaed and have some value to the case? So we spent a lot of time recreating how we want to do everything. We used resources that Dr. Gordish and Dave at Twin Valley helped us with using their OCR manual on the inpatient side. We used a bunch of different resources that's out there and kind of created or picked and choose what we felt was most applicable to the outpatient setting. So we created a whole different workbook that really targets just the specific elements of competency that we're looking to restore. Sometimes people will come in and they don't need to know what their charges are. They're very well aware and they're happy to talk to you about them. What they can't do is rationally make any decisions based on that information. So we're not spending any time on the factual stuff. We're going to focus on the areas of deficiencies in their competency. What we started doing was creating a referral form that specifically outlines all of the documentation we're going to ask for from our referring courts. We wanted to standardize the process because what we learned was things like start dates for the restoration period. Different counties function different ways, and if we're going to create a system for the statewide, we probably got to get some uniformity going. So our whole goal was get it in writing first from the court, because now the court is directing all of us. Now we have something to respond to, and now we don't have to try to ask along the way or make up the date and hope that it's right. From there, when we receive the referral, we reach out to defendants and we conduct an initial competency assessment ourselves. Seems a little redundant. You know, if Dr. Tilley is seeing this person 1 week before I'm now seeing them in OCR for their intake, what's the point? Well, the point is we've seen a lot of differences in a short amount of time on cases that we anticipated might show a little more stability. I'm thinking of a couple examples where I know one case, there was a highly educated person who Dr. Tilley saw on the initiation of medications. Some of those delusions are still intact. A week later when I get them, they are ready to go for their evaluation. So perfect summary of who fits in and how things change. We had another one. Oh, I don't know if this still works.
Uh-oh.
There we go. We had another one where the person was very, very, very stable. Again, I see them a week later, and the person found a little bit of meth. Very different presentation. They didn't show up to their appointment and ended up getting pink slips. So what we're seeing is we want to reinitiate an evaluation to see, all right, what are their present day deficiencies, and then compare those. Because what it's going to show us is maybe what are the moving parts of their competency status. From there, after we initially meet with the individual, we'll assign them to groups to learn all of the factual elements of competency. And the reason we do this is, man, this material is just not that engaging. It's very hard to get somebody who might be having, maybe some emotional instability to focus on me talking about their charges for an hour. A lot more topics come up when you have a lot of other individuals. And most of the research indicates that the factual elements can be learned in group settings. When we feel like they have a grasp on those elements, we're going to move them into rational, individualized sessions. And now the rational topics would be things like, can you work with your attorney? Can you participate in meaningful dialogue to make well-informed decisions about, the future of your case? Does your perception of or version of events in question have reality-based insights, or are you able to rationally make decisions despite perhaps some delusional content or misinformation? From there, we every week have we have consultations with my leadership, Dr. Shannon Porter, Dr. Meredith Beltry. They're the forensic directors of NetCare's Forensic Center. So every week, I'm independently licensed myself, but I'm speaking with the experts who actually know what they're doing, and we're adjusting the plan as we go. Our whole concept was one size does not fit everybody because my competence and your competence do not mirror each other. So that moves us, here's a good slide. Yeah, this is the tool that we use, kind of our first assessment. I just wanted to throw it up there so you guys could see how we're outlining what does the front-end evaluation point out in terms of competency deficiencies and what do we see. More often than not, we're seeing them mirror each other. When we see differences, boy, are they drastic and impactful. So it kind of leads us into the conversation of who are good candidates for OCR. The easy answers are they're linked with treatment, they're medication compliant. This one has been surprisingly new to some people in the system. We need their contact information. We need to know where to find them, and if not, who is the person that's going to help them the most that we can then contact. If you don't know how to find them, there's no chance I'm going to find them. Can they get to appointments? If they're in Franklin County, we require that they attend first in person so that we can make the determination that they would be appropriate to manage these visits in outpatient settings, or in virtual visits, I should say. Do they have appropriate devices to attend those virtual visits? I am not trying to speak to you for an hour through your cell phone. That's probably not that appropriate, and I'm highly doubting any judges are going to be on board for that. So we require a tablet, we require a laptop, and you have to be alone. Those are the big ones. Do they have supportive family and collateral contacts? This one seems like maybe it shouldn't be that big of a deal, but you would be surprised how much we can do with a heads up from a family member saying maybe this guy's decompensating, they need to go to the hospital, and how we can work with the court to ensure that that's not used against their competency restoration status. Questionable candidates, the exact opposite. If they're not taking medications and we see psychiatric acuity, especially in lower or shorter periods of competency restoration, it's going to be low odds of success. What we often have to do in those moments is let the court know, hey, these visits are no longer productive. We want the court to tell us what to do. We're happy to move forward with an evaluation early, but it's going to be an evaluation where the person essentially can't participate in the restoration process. Inconsistent contact information. I'm sure this is shocking to everybody, but defendants love to change their cell phone numbers so you can't find them. It happens all the time. So we ask for email addresses, get some pretty hilarious email addresses considering we're kind of a legal program. People are very courageous in what they're willing to put out there. Homelessness, you know the game. I don't have to elaborate a whole lot on homelessness. Limited social supports, same thing. Previous failed attempts at OCR. This one is less of a questionable candidate to me today, and I'll share a little bit at the end. But if somebody has recurrently shown that they're not going to comply, that they're too sick to participate, that OCR essentially doesn't work for them, then maybe that's not the best person to refer again. So going back, we offer in-person and virtual options. One of the first things I wanted to do when we joined, and my leadership allowed me to kind of throw out this idea, was to implement a system using an online appointment reminder tool where we can send appointment reminders directly to your cell phone, to your email address, 72 hours, every 24 hours leading up to your appointment. It confirms the delivery of those appointment details, and the whole point was, well, I need to prove to the court that I'm actually doing what I'm telling the court that I'm doing, but we also got to prove that the defendant is it. So this is a way that we can show, no, you had the information. You are the only reason you didn't come. So that was step one. Step two is, again, I already mentioned this, we require in-person visits for defendants in Franklin County. These people are also in outpatient settings. They have lives to live. So we will work around with them, with appropriate considerations. I'm not going to see you Saturday at 8 a.m. if that's the only time you can make it. But we do try to work around people's lives. They're not in a jail, they're not in a correctional facility. That doesn't mean they're doing anything wrong. Non-Franklin County residents, obviously we're not going to make them travel to see us, especially if they're sentenced out of a county that isn't Franklin County. So we do prioritize video visits in those instances. What we've really seen is Hocking County does not have the internet service that we have here in Franklin County. Same with Fairfield County. So we've leaned on different court partners, probation officers specifically, who've helped us host visits at their court buildings for OCR candidates or defendants in their courts. So it's a lot of help that we're receiving. I wouldn't say we're initiating it, but we're certainly benefiting from it. Requirements for video visits, you gotta have internet, no cell phones, you have to use a tablet or a computer. And one of the reasons we make those stipulations is access to wellness can be used to fund purchasing those devices for these individuals. So there's not, if you say you only have a cell phone, well, let me refer you somewhere where we can make sure that this, goes a little bit more smoothly. Have to have quiet, alone space. We've had defendants take visits, one with Dr. Porter, who she was going to do an evaluation for one of my people who I said was ready early, and the guy takes the call from his doctor's office. It's probably not going to work out. They have to dress right, and they have to behave right. We treat it like it's court, and people get a mixed message, understandably so, that if they're at their house, they don't have to maybe function as professionally or as put together as they would if they're in front of a judge. What that doesn't mean is you don't have to wear a shirt, or you're allowed to eat your lunch throughout the whole visit, or you can have the TV on or play some video games or smoke cigarettes the whole time. So when we're making considerations for who would be appropriate for video, we have to make considerations for who's willing to take this seriously. So what's working? What we kind of figured was the lack of communication seemed to be a theme from both the OCR provider side and the court side. And one of the first things we started out to do was get rid of that lack of communication. So the easiest way to do that for me was step one, let you know when I receive a referral. You wouldn't believe how much that helps. And the reason that helps is maybe they didn't send us all the information. Nothing like sitting on a file with nothing to do and then realizing you couldn't do anything if you had all the information. So we're aware of errors early. It helps us and the court be on the same page with what is the actual start date for OCR. A lot of people think it can be the date it's ordered or referred. Okay, we're at the court's direction when it comes to this. Some counties treat it as the first day they participate in our program. It's fine with us, as long as we're on the same page. You know, we work for the court. So we just want to make sure that we have uniformity across our timelines. And with that, dictating the restoration timeline dictates our submission dates. We have to have our reports submitted within 10 days for municipal court cases, within 14 days for common pleas cases. Well, if the court doesn't give us a sure date, we're not exactly sure when to submit it. So now we run into issues like, well, why was this report submitted? Is it early? No, not from our side of things. But if we're not on the same page, unnecessary questions like that arise. Next, we notified defense counsel within 7 days. Now, these timelines are primarily in place for municipal court cases because we only have 60 days, more often than not 60 days for restoration. Within a week, if we're not having any success reaching the defendant, we're going to ask defense counsel, for assistance. We're not trying to throw anybody under the bus. We're asking for help. Like, hey, can we get this person so that we can keep them in the program? If defense isn't having any success, we're notifying the court, but we're asking the court for direction. What we don't want to do is tell the court what we're going to do, because that's not how this works. But we also don't want to, sabotage the case if we haven't been able to provide services. Kind of a good rule of thumb is if they haven't participated, who says it doesn't work? So what we want to do is let the court know that we haven't been able to do our part, should the court elect to make any adjustments to maybe increase our likelihood of success.
Am I going on here?
Sorry?
Next slide.
No, we're okay.
No, we're good? Okay.
Yep, we're good. So kind of moved into my next point. We're very vocal and quick to communicate anything impeding our provision of services during the restoration period. If somebody is psychiatrically ill, we're notifying the court and we're pausing everything. Because if you think about it, that could be a violation of their rights. If they can't appropriately participate, we need to clinically get them to a position or into services that might enable their participation in outpatient. We've had people hospitalized during the restoration period, discharged, come right back in, and now they're competent. Maybe not the way that we would design it as a community, but that does also look like a program working. We've had people who have had cases dismissed because they're at their final competency evaluation and now they're getting pink slips straight to the hospital. So there's a nice mix of everything in between. This also becomes helpful when maybe we're seeing behavioral issues. Me telling somebody I'm going to notify the court that they're non-compliant doesn't really do anything. The court saying that they're being viewed as non-compliant does a whole lot more. So part of this is to give the court the information that we have so that they, weaponize isn't the right word, but they can utilize that information to maybe support more optimal outcomes. So again, why does all this matter? We're looking for support from the court. We're not looking to violate people. We're looking for help getting people in our program and keeping them here, because what we're seeing is it's working. We have opportunities to intervene along the way. I'll outline an example about psychiatric treatment compliance in NetCare's new outpatient behavioral health clinic later in the visit. But the whole point of that little seed being planted is we had a defendant who really needed some psychiatric meds. We wanted to do an early evaluation because visits were not productive, and that kind of led to our supervised, not mandated or ordered or forced medications in an outpatient setting. Okay, re-referrals. This is a funny story. Dr. Gordish and I were talking about this before this presentation. I hope this is okay to share. Initially, I had reached out to Dr. Gordish a couple weeks ago complaining about cases being referred back to me. This person didn't comply. Why are they coming back? Nothing's changed, so what's going to be done differently? And in my face, everything has been done differently. We've had everybody who has been reordered on the same case comply eventually with the orders. And in the last week or two, we've seen more examples of defendants contacting me before I'm even aware of the OCR order or have received the referral myself. They've been calling from probation departments with probation officers. I'm having POs contact me individually about people I have no idea who they're talking about. And then 24 hours later, they were right and I was wrong the whole time. So what was a complaint to Lisa has turned into what appears to be the court being very receptive to maybe some of the critical feedback we're providing, or just my personal frustrations and venting and conversations that we have with them. What do these re-referrals also matter? You know, you can't say OCR doesn't work unless you try. And what we're trying to do is build a case for some of these cases so that maybe they're not frequent flyers in a system, and we can kind of pre-anticipate what the competency finding will be. This is where we are. This hasn't been done in the outpatient setting. This whole building a caseload of an individual, but this is what happens every single day in inpatient psych or bed days. You know, these are high utilizers, and this is a way that we're not duplicating services down the road. So with that, I'll give the example of NetCare's outpatient behavioral health clinic. We created a clinic basically because NetCare has a public side, a civil side, that has now interdisciplinary and psychiatric behavioral health care. So they have primary care, they have counseling, they have psychiatry, medication management, nursing services, everything. So I outlined the example of a defendant we had who was nothing but cooperative and compliant. This guy had all of the factual knowledge in the world, but boy, were his delusions fixed and intense, directly correlated to the offenses in question. So we notified the court that, hey, he's being very, very, very compliant, but without medication changes, we're not going to get anywhere. Do you want us to do an early evaluation, or do we want to consider some change? Fortunately, in this case, this person met criteria to be admitted to Twin Valley. The court did not do that. They asked us if we would be willing to enroll this person in our outpatient clinic, and basically it's a way for us to know this person is taking their medications without forcing anything. The way that we did that was transition them off oral medications into long-acting injections, and now we know the day they got their shot. We know their symptoms are going to be hopefully maybe decreasing along this predetermined timeline. And now this guy actually might be competent, and he's going to be housed in OCR instead of ever stepping foot in Twin Valley. And that's a pretty good success story, especially when you can't mandate meds in the outpatient setting. So that's kind of all the information I have. Do you guys have any questions for me that I can answer?
In the case you just described, did the court actually order medication over objection?
I don't know that I would say that. They ordered him to maintain compliance with treatment as determined by treatment providers, which fortunately for us, our civil program is still in-house. We're just working internally. We just don't share any of the forensic information with them, and they give us updates of what they're seeing. So essentially we didn't know if he's taking it, we didn't know, well now he's got a shot, we know this is what we're seeing. So it's been helpful to actually have the data behind, well, this guy's less delusional now, why? Not a lot of OCR programs probably have opportunities like that. And what we would like to see is maybe some way of transitioning more people into psychiatric treatment with our agency, just so we can monitor it and not have to release of information in medical records.